Hi there. My name is Lieutenant Colonel Mary Stuever. I'm one of the C-STARS trauma docs here at the University of Cincinnati. So as you can see there, I work in a collaborative agreement with the University of Cincinnati and the United States Air Force. For those of you who don't know, we have a program embedded here called the Center for Sustainment of Trauma and Readiness Skills here in Cincinnati, and our focus is training the critical care advanced class. So we put students through a week of didactics and then a week of simulations where they are validated that they can actually perform critical care in flight. So that's what we do here for the Air Force. When I don't have my Air Force hat on, I'm actually one of the trauma surgeons here at Cincinnati, and I'm part of the trauma department as well as the surgical critical care. Today I want to talk to you about thoracic trauma. This is very, very common and very high yield on things that you'll actually see. So we'll get started here. All right. So the overview of what I'm going to be going over today is anatomy, common injuries that you'll see, common procedures that can be done by you, and then also that you'll often witness when you're in the emergency room. And then I do want to go over chest tube assessment and management in the event that you're ever transporting a patient who already has a chest tube placed, whether they're a transfer from an outside hospital or whatnot, or if you're delivering them to another facility. Brief, going over anatomy. Don't forget that up here we've got our trachea, so that's a midline structure, easy to access, easy to see and evaluate, looking for injuries, as well as tracheal deviation is something we'll talk about in a little bit. But then also the main bronchus is right there, so your trachea then divides into the right and left main stem bronchus to go into your right and left lung. And that part is important because that's oftentimes when you hear about a right main stem intubation, it's when the ET tube is too far and has gone into one side, so you're actually not inflating both sides of the lung. So important to know your anatomical landmarks. Unfortunately, this one you can only see on a chest x-ray, but important to know. That's why the average endotracheal tube is between 24 and 26 centimeters in your average adult. So shoot for that for the lips, and that'll put you about in the right spot. Other things to know, obviously, your right lung is broken up into 3 lobes, so you have your upper, middle, and lower lobe. Your left lung is broken up into your upper left lobe and your left lower lobe, and on the left lower lobe you have your lingula. So those are the most common structures within the lung tissue itself. Don't forget that the thorax and the thoracoabdominal area really encompasses both the upper abdomen and the entire chest. So I think we fail to appreciate that even though the lungs and the chest are up here, don't forget, and often gunshot wounds to the lower part of the thorax will include abdominal organs, and so your diaphragm kind of rides at about the T7 seventh rib area, and so what you may think is just a chest wound will often involve the abdomen as well. So don't forget about that. Okay. Additionally, for anatomy as well as physiology, don't forget that breathing is actually a passive process. What we do is we contract our thoracic cavity muscles, including the external intercostal muscles and the diaphragm. And what that does is it helps open the chest cavity, thus creating a negative pressure in the chest, and therefore air rushes directly into your lungs. And so actually getting air into your body is a very passive, and it involves both it involves just changes in your pressure. So by taking a big deep breath, you create negative pressure within the chest, and that's how air rushes in. And converse to that, the diaphragm will relax, and your thoracic cavity gets closer when you expire, and therefore the air is pushed out. So breathing is actually a pretty passive movement, and it's something that we don't have to think about, right? So why do we care? Why do we want to know about thoracic injuries? Well, overall, it's the second most common cause of trauma deaths, and obviously anything we can do to prevent deaths is very important. When coming specifically to thoracic injuries, most injuries can be managed with just a simple tube thoracostomy. When you take all comers with a thoracic injury, less than 10% of all blunt injuries to the chest require actual operative intervention. So those patients rarely have to go to the operating room. Penetrating, because of the nature of the penetration and the difficulties and the things that are injured with a penetrating injury, still only about 15 to 30% of those patients even require an operation. So by and large, most of these are going to be managed with initially your care on the scene. So what the key to this is that we need to perform timely and appropriate procedures given to the underlying injury that the patients have sustained. We're looking at this X-ray here, and I don't expect any of you to be, an X-ray technician who can read these. But what I really want you to appreciate here is if you look here in the middle, remember I was talking about that tracheal deviation. So the trachea should be a midline structure. Here you can see it getting pushed off to the right. You can also appreciate that throughout the entire chest wall, you have a lot of extra space over here along the right side here, and there's actually no lung that you can see. And over here, you can actually see the pattern of the lung. And so this here, we kind of say that you should never have this diagnosis because it's such a prolonged process. This is the tension pneumothorax. Tension pneumothorax is actually a clinical diagnosis. It is a pneumothorax in the setting of hemodynamic instability. So you have your simple pneumothorax, which is just air inside the chest wall. But when you've now established hemodynamic instability, it has become a tension pneumothorax. So it's not necessarily an anatomical thing. If you were to see this chest X-ray and the patient is hemodynamically stable, which they probably wouldn't be given the degree of deviation, but at this point that would be considered a simple pneumothorax. So pathophysiology behind the tension pneumothorax, you can see on the right there has been an injury to the lung, most commonly from a motor vehicle accident or from a penetrating trauma where you actually have a hole in the lung. And then you also have an air that is coming from the outside. So as that air continues to leak from either the outside into the chest or the air is leaking from the injured lung itself, you see that the air is increasing in the chest cavity, but there's no outlet for it to go out. And so what it actually does is causes the chest to push over to the left. Well, when that becomes hemodynamically compromised, isn't necessarily from an airway standpoint, but because you can see here how the vena cava, inferior vena cava is being pushed over. And as that's pushed over, it gets compressed, and this decreases the amount of return to your heart, and therefore patients will get hypotensive and tachycardic because of the decrease of blood flow. So this is what we call an obstructive type picture because of the lack of blood flow back to the heart. So that's obstructive shock. So what you'll find, diagnosis, so typically the physical exam, the patients will have obviously respiratory distress. Their chest will be asymmetric because you've got different findings on bilateral sides of the chest. Again, like I said, tension pneumothorax, they've now become hemodynamically unstable. And by that, usually you're going to see that they'll be tachycardic, they'll be hypoxic, and then a late finding, which you don't really want to get to, is, and you want to intervene early with appropriate treatments, is that a late finding will be a decrease in their blood pressure and hypotension. Oftentimes you'll see distended neck veins. Like we were saying, there's an obstructive process. You can't get blood back to the heart, so it backs up in the superior vena cava and backs up into the internal jugular veins, and you can't actually see those veins distended in your neck. As we talked about, the tracheal deviation, so you'll actually see the trachea deviate away from the tension pneumothorax because everything's being pushed to the other side. So if you have a right pneumothorax, your trachea will deviate to the left. You'll have decreased breath sounds. Obviously, you can't hear lung tissue because there's just air there. They'll be hyperresonant, so if you percuss on the chest, it'll sound kind of like a drum because there's just free air there. There's no tissue in between to interrupt the spacing. Really, like I said, tension pneumothorax is a clinical diagnosis, and that's why none is listed. But oftentimes you will find on imaging that they'll have a pneumothorax and then they'll have those other physical exam findings. So initially the treatment, they're hemodynamically unstable, so you need to intervene, and this is where most of our paramedics will intervene on the scenes with doing a needle decompression. Now, I was classically taught when I was a resident as well as an EMT before I went back to medical school that a needle decompression, the classic teaching is the second intercostal space at the midclavicular line. Two problems with this. Number one, if you don't get in the appropriate place and you place it too high, you can actually get into the major vessels of the upper extremity or the upper chest, so you can cause injury to your subclavian vein and artery, which obviously is difficult to control. But as our typical population tends to increase in size and has more subcutaneous tissue, there's a fairly high miss rate on actual needle decompressions getting into the chest. So you're just sticking needles into the chest and not actually getting into the thoracic cavity itself and decompressing. So they have looked at going to between the fourth and fifth intercostal space in the mid-axillary line, which is the same side as a chest tube, so we're going to be going into that area anyway for placement of a chest tube. So that's now the classic teaching is on the mid-axillary line between the fourth and fifth intercostal space. So a needle decompression is really only a temporizing measure. This is not something that you're going to do and then say, hey, yeah, high five, we're done, move on. You really need to have a definitive placement of a chest tube, which would be the definitive treatment. If the circumstances don't allow for chest tube placement for whatever reason, you can consider close monitoring, and you can do repeat needle decompressions as needed, but really it needs the formal final chest tube placement for correction. So this slide, it'll be great because I can increase this for you. So you can see there to the left of the picture is just air, and to the right there's a line. You can see the lung tissue, and as I follow that down, you see how the lung kind of is compressed down, and you can see the extra air. So that is a simple pneumothorax. So that is just air in the chest. And looking at this from a more schematic standpoint, this is what it looks like. So on the right, or on the screen left, the patient's right, you've got normal lung tissue. On the left, you've got air. And this is just a simple pneumothorax. Okay. Diagnosis for this, again, same with tension pneumothorax. It's the same physiology. You have decreased breath sounds. It's hyperresonant. It's just air. There's no tissue in there to interrupt the air sounds. Oftentimes you'll find subcutaneous emphysema. So it's like that Rice Krispie underneath a plastic piece that feels like crackly. Once you feel it, you'll never forget it. The way we diagnose this is by imaging. Plain chest X-ray will pick up large or mild or moderate to large pneumothoraces. Now, some of our simple, small pneumothoraces that we just monitor and not necessarily treat may not be seen on a chest X-ray. Oftentimes in the emergency room, they'll, as part of the FAST exam, so that focused assessment of in trauma, where they'll add the views of the lung to look for lung sliding. So you can use ultrasound to diagnose a pneumothorax. Again, it has to be a little bit larger, and so it has to be a little bit more clinically significant and obvious. It's the CT scans are really where we find those small pneumothoraces that we don't necessarily intervene on. Treatment, again, is chest tube, and then if they have just a small pneumothorax, we can closely monitor them and repeat chest X-rays. Not all pneumothoraces are large enough to necessitate a chest tube. All right, so now on this slide, you see, obviously everybody can see that there's a problem with the right side of the chest. So this is a hemothorax, all right? So different from a pneumothorax in that now you've got fluid in your chest. So that's why it appears different on the chest X-ray. So the right side, the left side of the patient, right side of the screen is a normal lung, whereas on the right side of the patient, the left side of the screen, it's full of blood. So that's why it has that white appearance. So on X-rays, fluid shows up as white, or solid fluids show up as kind of a grayish white. So here you can see that now in the presence, you still have an injury to the chest wall. There's just the difference is that you have blood in that area. So On physical diagnosis, the difference between a hemothorax and a pneumothorax from a physical standpoint is you'll have, again, decreased breath sounds. Obviously, you can't hear the lung, right, because there's no lung tissue there because it's being compressed by something else in the chest space. But now you're going to have a dullness if you percuss that chest. So it's kind of like having a water balloon that's full. So if you tap on it, you have a dull sounding thing as opposed to tympanic when it's full of air. Imaging. So in order to really see a hemothorax on a chest x-ray, you have to have about 300 cc's and it has to be upright. So obviously not as easy to see if you've got like a small pneumothorax or a small hemothorax. Ultrasound is another good one, except this one it'll show up as fluid on the ultrasound. And then CT scan is sort of our gold standard of what we look for a hemothorax. Again, the treatment's the same. So you have your chest tube. If it's a small, simple hemothorax, oftentimes we'll observe those for resolution. But if the patient has a large enough one, they will require a chest tube placement. Classic teaching is a larger caliber is preferred, but I think you might see this change over time as more studies show that your smaller caliber tubes don't have any increased risk of retained blood products in comparison to the larger chest tubes. Obviously, the smaller chest tubes are much better tolerated than the larger chest tubes. So more to come on that, but for now, we'll still continue to go with kind of the larger caliber preferred. When we get involved from a surgical standpoint, the classic teaching is if you put that initial chest tube in and they put out 1,500 cc's, there's a surgical problem that needs to be fixed. That's not venous bleeding, that's an arterial bleed that needs to be fixed. So that initial presentation, if they present, they have penetrating trauma to the chest and they are unstable, that's a no-brainer. Those are easy. You take those off directly to the operating room. When it gets a little bit more dicey is when they've got this persistent bleed. And so looking at the numbers over time, they found that if you have 200 cc's per hour over 4 hours, that's more consistent with an arterial surgical problem as opposed to just a venous injury that will tamponade on itself for a stopover at a time. So those are kind of give you some numbers to look at when you're thinking about doing definitive treatment. One pearl that I want to share with you is that if you are transporting a patient and you are actually bringing the Pleurovac, and I'll show you where you can mark these, make sure you know what the current level is on the Pleurovac prior to departure, because they may ask you like, hey, why en route? How much came out? That's really, as you can see, can make or break a decision to go to the operating room upon arrival. So something to think about. So the other one is, layman's term is the sucking chest wound. What we call it in medical field is an open pneumothorax. So this is where you have both the injury to the lung and air in the chest, as well as an opened area into the lung itself. So this is a little bit different from a physiology standpoint in that air is going back and forth through the thorax, and so that's why you have the sucking sound. On physical diagnosis, this is kind of a no-brainer. You can see it. You actually hear the air being sucked in as the patient takes a deep breath. They will often have rapid breathing. It'll be labored. It'll be shallow. And again, you have reduced breath sounds. Just like with a pneumothorax, you've got air on that side, so you're not going to have this. You're not going to be able to hear breath sounds. Really, there's no imaging required for this one. It's obvious to see. Initial chest tube, and this is where you'll have those chest seals, and they're great. That's a great product that's made. So you slap the chest seal on. It has one side open to let air out, because if you don't let the air out, then that causes concern for a detention pneumothorax can develop, because you don't want that air. If you've got an injury to the lung tissue itself, it'll build and build and build. So you need to have those chest seals will actually allow the air to escape. If you don't have a chest seal, you can simply take any kind of dressing and then seal 3 of the 4 sides to allow that air to rush out. Again, these patients are going to be treated with a chest tube, and as I talked about, the temporizing measure, 3-sided, anything you can put on there with tape. And then the definitive treatment, oftentimes we'll take these patients to the operating room. We wash out those wounds, place the chest tube if they have a large enough pneumothorax, which 9 times out of 10 they do. And then we often will close the actual wound to the chest wall so that then you can have resolution of the pneumothorax. Another thing you need to be aware of when looking at injuries to the chest wall that isn't as common, but something that you need to be aware of because you can actually be one of the first people to encounter this, is an actual injury to the tracheobronchial tree. Now, these are pretty devastating. The mechanism of injury is going to be very high impact. So the times I've seen this when I was a resident and attending is tree trunk falling on somebody and actually like dislocate or disassociating the trachea from the one of the bronchioles from the trachea. So it's not an easy diagnosis to make, but you have to have an index of suspicion. And so this is where gaining the scene, what happened on the scene, what things look like, how the injury occurred can help the medical team at the hospital know to look for that based upon what you tell us about what happened at the scene. So, don't forget that if you're looking here closely, you have the larynx that's up here, so that's your voice box. Your trachea is right below that, so that's where you feel those rings in your neck. But right as it bifurcates here, there's your right main stem and your left main stem. Anywhere along that area, when you have an injury directly to it, is what I'm talking about. Oftentimes, patients will have pneumothorax. They'll have subcutaneous emphysema. When we get a chest X-ray or chest CT, they'll actually have air inside their chest wall in what we call the mediastinum. So something to think about. Tell us what the mechanism of injury is, because that helps us look for these injuries. These patients will have respiratory distress. They may have hemoptysis, so they may be coughing up blood because there's an actual injury to the trachea itself. Again, I talked about subcutaneous emphysema. You've got air leaking out of those structures, and it can come up into the neck and into the face, and it can be pretty obvious. They'll have decreased breath sounds if they have a pneumothorax associated with it. They may have some dysphonia because of the injury to the tracheal tree. So if it's close enough to the voice box, they may not be able to speak well. Imaging chest X-ray, where we really have a high suspicion of this, is if they have a persistent pneumothorax, despite that we placed a perfectly adequate, good, well-placed chest tube. They will still continue to leak air, and that we can't get a seal. The cervical subcutaneous emphysema, so emphysema up into the neck, even though you can see that with a pretty severe injury to the chest wall and a really bad pneumothorax, something to think about if you see that cervical emphysema, especially if you're on the scene. Subcutaneous emphysema from a bad fracture that's caused injury to the chest wall and ribs. Tends to take a little bit longer to make it up to the cervical area, but so if you see that, have a high index of suspicion. You may notice that your ET tube cuff becomes overinflated and you haven't actually put that extra air in there, so something to think about. What we'll actually do, so imaging chest X-ray, is a good way to see it, but really the gold standard is CT chest. And then if we have a high index of suspicion, we'll actually do a bronchoscopy on these patients. The definitive treatment is get a definitive airway distal to the injury, and this is not really something for you guys. This is more our anesthesia colleagues, but they will require a chest tube for any pneumothorax that's associated with the injury. They may require clamping of the chest tube if there's a persistent air leak, and that's something that we would tell to you as the surgical team that you need to worry. But really, definitive surgical repair is the gold standard. So like I said, the pearl for you is that even smaller injuries can be missed during our initial evaluation. So you may be the first to recognize this injury and have that high index of suspicion to pass on that information to those of us in the emergency room. All right, so this one is a little bit kind of dull. I'll get my arm out of the way for you. But here are rib fractures. So you've got multiple rib fractures. You see the break in the bones there on the left side. Let's talk about some rib fractures right now. Very common. You'll see this all the time, and I'm sure you've already seen it. What you really need to know for us is, obviously they're going to have on physical exam tenderness to palpation. You will see chest wall deformities, especially if they've got a flail chest. In the ER, we'll get a chest X-ray, CT scan. The CT scan really becomes important now because as we're starting to do more rib plating to secure those ribs, especially very severely displaced and distracted rib fractures, or flail chest. The CT scan helps us from a surgical planning. Treatment, the biggest thing that we need to know about rib fractures is pain control, pain control. You really need to be early with the pain control to prevent them from splinting so that they're not decreasing their alveoli and causing pneumonia. Like I said, we can use rib plating to help with pain control. If a patient has flail chest, you need to pass that information on. They'll actually have a floating segment of chest, and what we'll do is have paradoxical breathing. And in order to have a flail chest, you need to have more than 2 ribs broken in more than 2 places, and those need to be contiguous with one another. So like ribs 4, 5, and 6 broken in multiple places on the rib. So and where this becomes a flail chest is, remember I talked earlier that when we take a deep breath and we contract those intercostal muscles and breathe out, that flail segment can't participate in that movement. And so as you take a deep breath and bring out your chest, that part of the lung is actually, or that part of the ribs is going to actually decompress into the chest. And then as you breathe out, because it's not connected, it's going to go in the opposite direction. So that's what we mean by paradoxical breathing. And this is hemodynamically significant because if you are already having respiratory distress for whatever reason, and now you add on a flail segment, you have impaired our way to take a breath. And so that increases patients to needing to be intubated, left on the ventilator for a while, and even potentially trached. So the more we can do to help with our pain control, and this is where rib plating is starting to play more of a role in helping with those flail segments. But really the pearls for you is pain control for transport. If they are hemodynamically stable and you want to give them some pain medication, I really highly encourage you to do it. Consider positions of comfort too during transport. So patting those areas if you're transporting a patient through, a long period of time, or you got bad weather, consider how you can make them more comfortable, because that will decrease the amount of pain medication that you need. Also, if you're on any kind of rotary wing or fixed wing, the vibration of the plane really wreaks havoc with that pain. So be really quick to treat their pain and treat it effectively. So I want to review real quickly for you the thoracic procedures that you could perform. So we'll first talk about needle decompression. And again, the second intercostal space, midclavicular line, is your classic teaching. Again, don't forget the high miss rate. And then for needle decompression, the 4th and 5th intercostal space, which the anterior axillary line is right along here. Same side as the chest tube, and we use the nipple level for gentlemen, and then for females, it's the inframammary line where you want to put that needle decompression. Those are, I think, pretty standard. The needles for doing the thoracoscopic needle decompression. Okay. So chest tube placement, not as common for you guys to do, but if you're in the emergency room and you're wanting to help out, what we generally will do is try to place the patient's arm above their head. Our goals is the 4th to 5th intercostal space, mid-axillary line. And so since it's difficult to count ribs, on females, look for the inframammary fold, and on males, just right at the nipple line. Remember, that's about the 4th intercostal space is the nipple line. Well, if we can and we have the time, we want to prep and drape and give them some anesthetic. I usually like to use lidocaine with epinephrine and really give them a good nerve block there so that it's as comfortable as possible. Also, you can use some conscious sedation as well. I like to use ketamine to help make this a little bit more of a easier process on the patient. You want to stay on top of the ribs when you're going in. So on the bottom part of your rib, you have your neurovascular bundle. So the neurovascular bundle is your intercostal nerve, artery, and vein. And these bleed really crazy if you get into them. So as you're putting the chest tube in and placing your Kelly to get over that chest tube or to get over that rib, you go on the top of it, and that avoids the neurovascular bundle. You want to pop into the chest, usually place a finger and do a finger sweep, especially since some of our trauma patients, this isn't their first time having had a chest tube, and so they may have some lung stuck up there. And to safely get it in, you want to kind of do a finger sweep to clear the path for your chest tube. Or if you feel it's real stuck, maybe we should do this underneath interventional radiology. You want to direct the tube posterior and superior. It should go in really easy, no force. You never want to use force with the chest tube. It should just slide right in. I'll show you where to look for, make sure that all side ports are within the chest. Otherwise, it's not an effective chest tube. And then you want to suture that into the skin and then dress it with an occlusive dressing. That will help with that pneumothorax and the resolution of the air. And then we always get a chest x-ray to confirm position. So we'll take a look on how to assess these chest tubes and do the management. So this right here is a perfectly placed chest tube. So it comes into the side and it goes right up to the top. Now, things that you need to know. So this blue line that's blue on the outside of the chest tube, when you actually look at it, there's a break right there. That break in the chest tube indicates where the last hole is on the proximal portion of the tube. So before this line are all of the holes to do the drainage. So those are holes actually in the chest tube. That where that break is, that break needs to be in the chest cavity. It can't be sitting over here on the outside of the wall of the chest, because then that's an ineffective chest tube. So beautifully placed chest tube. So as I was talking about right there, you see here is that last hole, the break in the blue line. That tells us that's where the last hole is. So all of these holes proximal to that need to be in the chest. And then you see here that it's at the side, secured in place, and usually about 10 to 14 centimeters, depending upon how thick your adult's chest wall is about an adequate depth of a chest tube. And then if you're going to transport a patient over a long period of time, you want to look at where that chest tube is and make sure it's in good position and that you know the depth of it, because these things, believe it or not, get pulled, yanked, and you need to know. If it does get pulled out, don't reinsert it. Just pass on to people that it fell out, or that it's, when you picked them up, it was at 10 and now it's at 14. That way people know what's going on. So looking at the chest tubes here, they're just different types. This is pretty standard, your standard fenestration, the holes in the tube. This one's just a straight one. It's a thoracic drainage tube. And then this one's a bent chest tube. Those are just different ones that you might see. This is an actual pleurovac. So in order to treat a pneumothorax, what we need to do is we need to seal off the atmospheric pressure to the chest wall itself. And so when you hear the words water seal, that's this chamber right over here, and I'll talk more about that. But that chamber actually has water in it, and that seals off the atmospheric pressure in order to let us resolve that pneumothorax and kind of get the air out of the chest. So this is the atrium. This is pretty standard. I don't know of many other chest tube trays. There were some when I was in Afghanistan that were very different. If you go to other countries, they have different setups, but in the United States, atrium is pretty much by and large the one that you'll see. So when you do that water seal, they're automatically set to a -20 suction. So this is not actually setting to the suction of the wall. So when you're on water seal, is what we call it, then there is a -20 suction to the chest wall itself. What we do is if you need to suck air out, and then within the first 24 hours, if there's a hemothorax and you need to get that blood out, we have to hook it up to suction. And you know that it's hooked up to suction when this bellows is out. So this is a bellows, so it's like those things when you see old-time cartoons where they're blowing air into a fire pit. That's a bellow, and that's what we call the bellows. And that right there is where you see it's out. That means the suction's functioning and working. So on the actual chest tube chamber itself, here's the negative pressure that you see. That's the bellows. So this is out. That tells you it's hooked up to suction and the suction's functioning. And then that's your water seal chamber. So things to note when you're picking up patients, then you also want to notice if there's an air leak. And so you look in that chamber that I was showing you earlier, this chamber right down there. If there are bubbles in the chamber, that means there's an air leak, and there's not really much that you need to do or worry about as far as that goes. It's just needed to make a note of it, or if one starts to develop. And what you can see is that there are bubbles in the air, and when there is no leak, there's supposed to be no bubbles. But if there is actual leaking, and the times you'll see continuous air leak is when somebody actually has damage to the lung tissue itself. It'll take some time to heal. So at this point, I think we've kind of hit all the topics of chest wall injuries and the procedures that you can do in the field to help assist taking care of these patients. So with that, and I guess there's no real feedback for questions now, but feel free to contact me if there's any questions or anything that I've said that didn't make sense. This picture here is from my training flight. When we do the CCAT training, we also take our patients with mannequins. So these are all mannequins. These are not real patients, but we have high fidelity mannequins that we can take into, this is a C-130 that's part of the Kentucky Air Guard. And we'll do a live flight. So we'll load up the mannequins, put them through scenarios, and each one of them has a diagnosis. And then we can control the mannequins with an iPad and have them do the different things like get a pneumothorax, eyes open and closed, have seizures, all those kinds of things. And then we'll actually take some of our students up and do a live flight. So it's about an hour flight up in the air on a C-130. So you can see this is how it is. So tight. There's 6 patients and 3 CCAT teams, or 6 CCAT teams. So it gets pretty tight in there, especially too when you consider the aeronautical crew that helps assist, and then as well as the cadre, the teaching staff. So. Again, feel free to contact me, Mary Stuever. I'm one of the trauma surgeons, and I would be happy to answer any of your questions. Thank you so much.